I'm Diane Alexander. I'm an economist at the Federal Reserve Bank of Chicago. First, let me say off the bat, nothing I'm going to say today represents the views of the Federal Reserve Bank of Chicago or the Federal Reserve System. With that out of the way, I've been given the somewhat difficult task of kicking off this great conference by describing the US healthcare system's incentives, motivations, and opportunities in 15 minutes or less. So please bear with me. Also, thanks so much for inviting me to this great conference. I'm excited to learn from all of you the rest of the day. So the goal of my part of the talk is to give some institutional background on the US healthcare system with the idea that in order to leverage the US healthcare system to impact educational disparities, we first want to make sure we're all on the same page with what's going on in the system itself. And so my remarks today are going to go through kind of 3 steps. I'm first just going to give a really high-level overview about where people in the US are getting their insurance coverage from, and in particular where kids are getting their insurance coverage from. And then I'm going to switch gears a little bit and go a little bit deeper into the incentives that these insurers are providing for the key actors in the market, so the, in particular, beneficiaries and providers. And then finally, at the end, I'll spend a little bit of time just describing one project I have that's my kind of small contribution into this space of leveraging the healthcare system to affect educational outcomes, which is a new paper that I have with Molly Schnell, who will soon be at Northwestern, that looks at the effect of increasing Medicaid payments to primary care doctors on access in health. And we also find in that project that increasing the amount primary care doctors are paid under Medicaid is associated with reduced absences for children. Okay, so let's get started. This is what this system looks like from a really high level. So I'm just going to go through very quickly these different pieces of the pie and then talk a little bit more about the details of the incentives. So everyone in this room, I'm sure, knows the US has this kind of very complicated hybrid system where we have a large private insurance sector existing along 2 big public insurers, Medicaid and Medicare. But by far the biggest chunk of the health insurance coverage landscape is employer-sponsored insurance. So this, even in the period after the Affordable Care Act, where other options have gotten bigger, still about half of the US population is covered by insurance gotten through their employer, and this includes also half of kids. So I'm not going to spend a ton of time talking about employer-sponsored insurance. I don't imagine that will probably be kind of the bulk of where people are talking about in the rest of the conference, but just to remind everyone that half of kids are getting their insurance through this type of coverage. The employer-sponsored private insurance sector has historical roots in wage freezes during World War II. So employers started trying to attract people over to their companies by offering benefits. It was kind of codified into tax policy, and so has been pretty stable since then. These people are covered either through their own job or as a dependent, and the average employer contribution is about 80% of total families for individuals and about 70% for families. And the employer-sponsored insurance itself is kind of covers a lot of variation in terms of generosity and plan type, which is something that I'll come back to a little bit later on. The next biggest piece is where I imagine we're going to be spending a lot of time today, which is Medicaid and CHIP. CHIP stands for the Children's Health Insurance Program. I'm lumping these 2 together. Medicaid and CHIP in some states are jointly administered as kind of one program. In some states, they're administered separately. But Medicaid and CHIP together cover about 20% of the US population and about 40% of kids. And these are low-income and middle-income children. Almost all states cover children up to at least 200% of the federal poverty level, combining Medicaid and CHIP. So this is a pretty generous program in terms of eligibility, especially compared to what's available for adults. 19 states actually cover children up to 300% of the federal poverty level. So for low-income children and middle-income children, this is a pretty generous program. For adults, there's much more variety across the US, And in particular, eligibility is and generosity of the program is going to depend a lot on a state's Medicaid expansion status under the Affordable Care Act. So before the Affordable Care Act, and in states that haven't expanded, Medicaid eligibility for adults is categorical rather than just being based on income. And so it's not enough to just be low income. You also have to be a member of one of these groups, namely usually low-income children and parents, pregnant women, and the disabled. In expansion states, things are much more uniform, with eligibility for the program being up to 138% of the federal poverty level. And Medicaid and CHIP not only is important for what we're going to be talking about today because it's covering a lot of children, and a lot of the children that I think we're particularly interested in when thinking about educational disparities. It's also interesting from kind of a policy perspective because there's a ton of experimentation that's going on in Medicaid and CHIP because these are programs that are administered at the state level, and we have a lot of states. We have a lot of opportunities for different states to kind of try out different things, and so I think there's a lot that we can learn from what's going on in different states in Medicaid and CHIP. The next biggest section is Medicare. I'm not going to spend a lot of time talking about Medicare in a program looking at early childhood education, but for completeness, Medicare covers about 14% of the US population. This is, of course, a federal insurance program for people 65 and over or with permanent disabilities. Actually, about almost 20% of Medicare beneficiaries are people under 65 with permanent disabilities. The other reason that I want to make sure to mention Medicare is because despite the fact, so Medicare is about 14% of the population in terms of coverage, but it's much more in terms of spending. And it's been shown by several different people that what Medicare does is important, especially in the payment landscape. So kind of when Medicare starts changing things, that a lot of the private insurers follow along. And so they do have kind of an outsized influence when we're thinking about the different incentives that insurers are using, especially for things like paying providers. The last kind of small type of the last chunk of insurance that I'm going to talk about is the individual insurance market, the non-group insurance. This is even after the Affordable Care Act, which opened the ACA marketplaces. This is still pretty small. It's about 7% of US population, about 6% of kids. And these are people and families that have purchased plans through an ACA marketplace or have individually purchased insurance outside the markets, the ACA marketplaces. The Affordable Care Act greatly expanded this slice of the pie, and in particular made purchasing insurance individually much cheaper for low-income people through a couple different subsidies. The first is a premium tax credit that people are eligible up to 400% of the federal poverty level that reduces marketplace enrollees' premiums. So this makes it cheaper to actually get the insurance coverage. And then for people on the lower end of this income range, up to 250% of the FPL, there also available are cost-sharing subsidies, which makes it cheaper to use the insurance once you have it, reducing the out-of-pocket costs of things like deductibles, co-payments, and co-insurance. I'm not going to talk about military and veterans. That's a pretty small piece of the pie, and also I don't think applies very well to the topic today. But I do want to mention the uninsured. So the Affordable Care Act was very successful in increasing insurance coverage in the US, both by expanding the individual non-group insurance market and Medicaid. But still, there remains a pretty big fraction of people in the US that don't have insurance. Around 9% of the US population in 2016, about 5% of children remain uninsured. And in surveys that ask people why they remain uninsured, it's still kind of the same reasons that it always was. Cost is still the most commonly reported barrier to coverage. Not all of these people may be eligible for free or subsidized coverage. And as well, it's likely that many of these people are simply kind of not aware of the coverage options or face other kind of behavioral barriers to enrollment. These people tend to be non-elderly adults, so not eligible for Medicare. They tend to be in families where at least one member of the family is working, and of course, low income. Okay, So now I'm going to switch gears and start talking about financial incentives. So how does everyone get paid? And the reason that I think it's important to think about financial incentives today is because when we design these financial incentives for things like hospitals and doctors, we're kind of shaping their preferences over what types of patients that they're going to want to treat the most. And so it's important to kind of think about the implications of the different payment systems that we're using. And then also there's, again, a lot of experimentation in this payment space. And so I think that's where there's a lot of opportunities to do things like leverage the healthcare system as it's experimenting. Okay, so I'm sure I don't really need to talk about this, but what's the purpose of health insurance? So the purpose is to help people pay for care and protect them from unexpected expenses. And the health insurers are going to be the ones who are determining a lot of the payment landscape. And what they're trying to do is to design a product that is essentially kind of a bundle of incentives for patients and providers, such that first there's demand for a plan, so people will sign up for it. There has to be financial coverage for the beneficiaries, such that they'll want to sign up for the plan. There have to be enough provider participation to keep the beneficiaries happy and to treat them. But beyond that, the insurers also want to make sure that by the act of covering people, they aren't encouraging them to use wasteful care. And they also want to make sure that the way that they're paying providers isn't incentivizing providers to provide low-value care. So this I will not spend a lot of time on. I think even just from our own experience, people pretty much know how health insurance works on the patient side. But the basic problem of insurance design on the patient side is insurers are trying to design a product that will provide for unexpected healthcare needs, but they also need to take into account the fact that when people are insured, they face a smaller share of their medical costs and may consume kind of more care than is needed. And also that people are kind of selecting between a bunch of different plans, and so people may choose generous plans. The people who choose generous plans may be likely to require more care. And so on the patient side, insurers essentially have a menu of different types of out-of-pocket costs that they vary in different combinations. And this is what determines these different types of plans. Things like PPOs and HMOs, high deductible and no network plans are essentially kind of different combinations of these insurance design elements. So things like the network of providers, premiums, deductibles, copays, and coinsurance. On the provider side, the insurers are facing kind of a similar type of issue, which is that they want to pay doctors, of course, for their services, doctors and hospitals and all healthcare providers. But they also want to pay them in a way that incentivizes them in some way to give kind of the right amount of care, taking into account that, of course, healthcare providers have in mind the best interests of the patient, but they're also businesses that have profit incentives. And so kind of the traditional way that provider payment had been done and is still done in some cases, in many cases, is kind of to just pay the provider based on a list of prices for all the different things that they do. So this is called the fee-for-service system. And here, if you pay people based on everything they do and you pay people more for kind of more intensive things, you create kind of pretty clear volume incentives. So on the margin, providers have a financial incentive to do more things and potentially to do more expensive things. And so because of this, and kind of combined with the very high level of health care spending in the US, and as well as the growth in healthcare spending, there's been a pretty strong push to, in the policy space, to come up with ways to dampen these volume incentives and to think about how to tie provider payments to things like measures of performance or quality. So I'm just gonna, again, pretty quickly go into a little bit more detail into two of these categories, the two biggest provider payment categories, hospitals and doctors. So hospitals, and again, we care about this because kind of hospitals, there's always limited capacity, and the way that we design these incentives across the different payers is going to create incentives for hospitals and doctors to kind of have preferences over different types of patients. So the main payment systems for hospitals, there's again this kind of historical fee-for-service system. In the 1980s, Medicare switched to using a by diagnosis system called DRGs, which are diagnosis-related groups. In this system, hospitals are paid based on the diagnosis of a patient rather than on kind of all the things that are done. So this has kind of the opposite volume incentives. If the hospitals do more things, they get no more money. They're just paid on kind of the expected cost of treating that type of patient. And also sometimes hospitals are paid based on the number of days in a hospital, which could reduce the incentives, volume incentives within a day, but potentially make hospitals want to have people longer. So private insurers, again, are kind of a grab bag. They're using all of these different types of payment systems. Medicaid usually uses per diem or DRGs, depending on the state. And Medicare, as I said, in the 1980s, switched to this diagnosis system. They also have recently implemented a bunch of kind of large pay-for-performance programs for hospitals, which with the idea being that hospitals will be penalized for doing things that we don't like having a lot of readmissions or having a lot of people get hospital-acquired conditions. Okay. Doctors have also historically been paid fee-for-service. Again, the basis of payment is per service provided. But there has especially been a strong push of coming up with alternative payment models to control costs on the doctor side. The kind of extreme opposite from fee-for-service on the doctor side is capitation, where here doctors are paid on the basis of per patient per time period rather than on what's done to the patient. The analogous system to DRGs on the doctor side is bundled payments, where kind of the episode of care is the basis of payment. So something like an outpatient procedure plus the services provided during a window of time around the procedure. And then there's also a lot of different flavors of pay for performance on the doctor side. Things like bonuses at the end of the year if you exceed a quality threshold. That being said, so there's been a lot of experimentation in this space with doctors for a long time. The bulk of the revenue is still coming from fee-for-service. So in a recent AMA survey, they asked doctors if their practice was getting revenue from these kind of alternative payment systems. Actually, a pretty large fraction of doctors are reporting that their practice is using one of these systems across these different types. Around each of them tend to be from like 20 to 30%. Of these using one of these alternative payment systems. But if you ask about the share of practice revenue, it's still very much coming from fee-for-service. So despite the fact that we've had kind of decades of experimentation in this space, still fee-for-service is where most of the revenue is coming from. So now I'm going to, in the last few minutes, switch tacks again and talk a little bit about my own work. So there have been a lot of studies in economics on things like the role of physician payment on treatment choice, looking at things like C-sections versus vaginal births, and on intensity of procedures, on things like technology adoption. In a recent project with Molly Schnell, we look at whether increasing Medicaid payments to doctors improves access and health among beneficiaries. And the kind of background for this project is that there are big disparities in access to care between the privately insured and those in Medicaid in the US. So in 2009, for example, about 90% of doctors were reporting that they would take a new privately insured patient, whereas just about 2/3 were accepting new Medicaid patients. And if you ask why that is, the doctors would all said, and this is true, that they were paid much less for treating a Medicaid patient than a privately insured patient. Of course, that doesn't necessarily mean that if we just pay them more that they'll necessarily all of a sudden start taking on a bunch of Medicaid patients. And so from a policy perspective, we wanted to look at this question a bit more carefully. Because there are also a lot of other reasons that doctors may not be taking on Medicaid patients. And the setting that we use to look at this question is the Affordable Care Act's primary care rate increase. This happened in 2013 and 2014. And what it was that states were required to increase Medicaid payments to Medicare levels for primary care services. So Medicare is administered federally. Medicare is administered federally, but Medicaid is administered at the state level. And so there's a ton of variation across states in how much doctors were being paid to treat the exact same new patient. So before this program went into effect, there was variation on the order of like around $50 to over around $150 across states for literally doing the exact same service code. This is a new patient visit of intermediate complexity. And then what happened in 2013 and 2014 is it was mandated and totally federally funded that all states had to increase their payments up to the Medicare level. So you have a situation first where the distribution kind of collapses upward. All of the states end up in what was before the top 20% of the payment distribution. There's still a little bit of variation because Medicare has some geographic adjustment factors, but for the most part, everyone kind of collapses up to these higher rates. It was unclear initially whether this would be continued. In the end, it wasn't. So then in 2015, you had many states, the federal funding disappears. Some states stay at the higher rates, but many states drop down to what they were doing before. So the question of this project is we wanted to see what would happen to the Medicaid beneficiaries. And so what we find is that these higher payments are associated with increased program participation among doctors. We see more office visits and better self-reported health among beneficiaries. But I think particularly relevant for today and my contribution to this space is we also see Medicaid beneficiaries reporting fewer days of missed school in states that increased the payments the most. So this is just a very simple way to show our data. On the x-axis is the increase in dollars before and after the rate increase. And on the y-axis is just the change in the outcomes. So basically what I just want to show is that we see the biggest improvement in all of these outcomes in places that increased the payments to primary care doctors the most. And the dashed line, this is all for Medicaid beneficiaries, and the dashed line essentially shows that nothing is happening at the same time for the privately insured. So I don't really have time to go that much more into the details of that study. I'm happy to talk about it later today with you all. Just to briefly wrap up so I can pass the baton to my other great panelists. There's a lot of work going on currently. There's a search for reforms that decrease spending and or improve outcomes, hopefully both, in the healthcare space. This is leading to a ton of policy experimentation, and there's really a lot of space here to play with different incentives and lots of opportunities, I think, for the things that we're going to be talking about throughout the rest of the day. I think that my paper with Molly is kind of, I take it as suggestive evidence that physician payment policy is a promising lever to increase things like utilization and outcomes in low-income populations. Again, we find that increasing Medicaid payments to primary care doctors has these positive outcomes on access and also improvements on self-reported health and school attendance. But I just want to leave on kind of a cautious note. Again, I think this is something that we're going to be talking about a lot through the rest of the day. I showed a kind of a positive outcome of the changing incentives doing kind of what it was intended to do, but I could have just as easily showed you a project where it didn't do what it was intended to do and then sometimes backfires. And so changing payment policy doesn't always work exactly as it's intended. The details are really important. The evaluation, careful evaluation is very important. And also scaling, which I know is something that everyone in this room is interested in. So thank you so much.
Jocelyn and I came as a team, and we're going to be a team throughout. So great.
And I just want to say thank you. I feel like I could have skipped my grad school course in health policy. Had that 15-minute tour de force review.
Right. And you set us up really well, Diane, in terms of context. We're going to go a little bit deeper on some of those points and give you some what we hope are very concrete examples and hopefully even some guidance on how to use some of the tools in Medicaid and CHIP to advance what we're all trying to advance through this, our work here and when we go home in terms of how can we use Medicaid and CHIP to help advance healthy development for children. So we're very excited to be here. Jocelyn and I are going to talk about some of those basic concepts in Medicaid and CHIP, but also draw on work that we're doing together with some other folks in the room as well, looking at what is happening through various interventions to enhance and promote social and emotional development in the well child visit. So we're very excited about that. You're going to push the buttons. You're going to push the buttons. Thank you. Thank you. I think you've seen some of these pie charts a little bit earlier. What we wanted to just kind of set the stage for our conversation is talking about the role that Medicaid and CHIP play for both children, and we're going to talk about parents too, because as we all know, when we are thinking about what to do to enhance the health care of very young children, we have to think about their parents as well. And this is not always what's happening, but we really need to pay attention to this. So for young children, birth to age 3 in the United States, a very large share of those children are covered under Medicaid and CHIP. It's almost half of those children. Not quite as robust for their parents, and partly what's driving the train here, as Diane talked about, is the opportunities that states either availed themselves of or didn't with respect to Medicaid expansion under the Affordable Care Act. And so we have a growing number of adults, parents included, who are covered under Medicaid, but there's still a long way to go. It's much more likely that a child, an eligible child, will be covered under Medicaid than a parent. And one of the things I want to flag, because I think for the, last 20 years or so, there's been a very, very strong emphasis, particularly for children, in making sure that all eligible children were enrolled in coverage. And so many of you in the room, I know it's been kind of my reason for living for a really long time was, to make sure that children are enrolled in coverage if they're eligible. And in fact, we had remarkable success and have an uninsurance rate for children that's as low as it's ever been. But if you were looking at the newspaper or your news feeds yesterday, you saw that for the first time we're seeing an uptick in uninsurance among children. And we need to ask why that's happening. We can talk about some of the reasons that might be happening, but also what we can all do to stem that, hopefully it won't be a trend, but stem that occurrence and get things back on track, because everything that we're going to talk about in the next few minutes with respect to what can happen for Medicaid beneficiaries can only happen if those people are Medicaid beneficiaries. They have to be enrolled in the program in order for these opportunities to be available to them. Just a little more kind of context setting, what kind of services and care do we want for young children? Primary and preventive care. Many of you, that is your reason for living, which we're really happy about. Part of that, developmental screening, but as you'll hear, I think probably throughout the day, screening is great, but what do you do once you identify a problem through screening? We're going to talk about the opportunities through Medicaid to make sure that we address those issues when screening reveals that there's a problem. We want that to happen too. We know so much more now and are paying much more attention to what are called the social determinants of health, those outside conditions that really do affect health, and we want to be sure that we have tools to address those needs so that we're paying full attention to what matters for good health. And again, when we're talking about the health of children, we want to be sure that those giving care to those children, whether they're parents, other family members, caregivers, are healthy as well. And we're going to talk a little bit about that. One of the strongest tools we have is the Early and Periodic Screening, Diagnostic, and Treatment, the EPSDT benefit. which is a comprehensive benefit for children who are enrolled in the Medicaid program. And you can see what some of the aspects, some of the components of the EPSDT benefit are, and I just want to point out we'll be talking a little bit more about that very first one, the comprehensive health and developmental history, because it includes a risk assessment for the child, and we're going to talk in a little while about how to leverage the opportunities under this comprehensive benefit to kind of make things better, to enhance what we want to see for children. We'll also be talking about some of the other services that are available that we see at the bottom. I like to talk about the EPSDT benefit as the gold standard for children in terms of a health benefit, but also the responsibility that we all have to make the gold standard the solid gold standard. It's there and it's available, but there really is a very strong role for advocates and others to make sure that that children are getting what they're eligible for. And so, it takes, I think, constant vigilance and action. Jocelyn.
Okay, so I'm going to confess I'm going to start dark and then go a little more optimistic. So let me start with the dark, and I want to pick up a little bit on some of what Diane said about what motivates health insurers. And you will notice that in her list of things that motivate them, supporting strong early childhood development and access to language and supporting parents as caretakers was not on their list of top priorities. So I think part of what we view as our job is to give you a sense of what the tools are in Medicaid so that we can put that on their list and that we have financial incentives aligned so that they feel like part of doing a good job and part of meeting their obligation to make some money, which they do have an obligation to do, is consistent with what we want to see. Like, what are the activities we want to see? So just to say that, I don't think it's on the list yet, but we want all of us to get it onto the list.
We're putting it on the list.
Putting it on the list.
Okay.
The other thing I want to flag, and it's super obvious, but I feel like it's a dynamic that underlines our whole conversation today. A lot of the payoffs associated with the amazing work that you all are doing do not accrue to the Medicaid managed care plan, that if we can get them doing a good job on this, right? It's going to maybe accrue to the education system. It's maybe going to reduce child welfare costs. And so I think that's something that we need to wrestle with as we go through this conversation. And we have a few ideas, but let me just be honest, we don't have answers. So we'll talk about that a little bit. The other piece of my bad news, before we turn to good news, is even though Medicaid is a foundation for this work, it has to be part of that community-wide model that Dana was talking about. This is not a top focus of the nation's Medicaid directors right now. They are incredible public servants. They are good-hearted. They would like to be working on kids, but the set of issues coming at them are things like, what do we do with the nursing home population in the United States? What do we do with the opioid epidemic? And so we just pulled for you to give you a little flavor of our uphill situation from the Kaiser Family Foundation, which every year talks to every single Medicaid director in the country. They get on the phone with them, they chat with them. What are you thinking about? What's on your mind? This is a list of what's on their mind. You will see that children are not on the list. So that, again, is part of our job. And one of the things, though, because Donna and I are optimists, one of the things we did is we looked at their list and we thought, actually, a lot of things you're talking about really are about kids. And we're going to help you think about how what you want to do requires integrating children. So let me just give you one example. Strong focus on social determinants of health. A lot of times that's about the homeless person living under a bridge who's cycling in and out of an ER and a hospital and a psych ward, who would be better off if they had housing. We, all of us, are also going to make it about for a family with young child, if they are facing instability in their housing situation, if their mom is absolutely overwhelmed because she's dealing with an immigration issue, that's part of what we're going to do as part of social determinants of health. So we starred the places where we think we have an entryway, and we want to build on the focus of the Medicaid directors and move ourselves in there. But we are not naturally at the top of their list yet. But there are, and this is why we're going to be a little more upbeat. We're going to get to, there are some great shining stars, and Medicaid directors tend to copy each other a little bit. So we can lift up those shining stars, and we've got them in New York, and I know we have some of the leadership from New York here in Oregon. They kind of travel as a group. So we're going to try to lift those up, and we'll talk to you about those. I did, before we jump in on that, just want to pick up on one more of Diane's point, which is this shift to value-based payment. And I think it's something that gives us an opportunity with respect to kids, because value-based payment is instead of paying you for seeing a kid 7 times, we're going to pay you for improving that child's outcomes. And so that's our opportunity. We need to have clear articulation of the outcomes, whether it's some of the scores that you are looking at in your research, and that's what we want to start paying for, instead of just, they need to have visits, but instead of just volume of visits. And so we are seeing a little bit of movement in this area with respect to kids, primarily kids who are very high cost. So, but we can talk a little bit more about that opportunity as we go. Okay, is this one me?
Go ahead.
Okay. All right, so now we're going to go a little more upbeat. So we actually think there's a lot of things that can be done with the energy and work of folks in this room and around the country. And one of the first things goes right to that issue we flagged, which is we want to align the financial incentives for our providers, for Medicaid managed care, to do the right thing. And we are starting to see there's some flexibility in the Medicaid law to say to Medicaid managed care companies, you got to do your job, cover hospitalizations, et cetera. But if you do a really good job in some areas that we as a state have identified as a high priority, we can give you a 5% incentive payment. And so a lot of the activity around this has, again, been about adults, but I think we want to take this flexibility and turn it and make it about, you get an incentive payment if you've set up effective parent training programs on how to parent young children in the early years. So that's definitely something to look at. Another example is states are all required to have a detailed quality strategy. I know many of you are probably experts on the quality metrics for kids. Some of those metrics include things like, what's the rate at which we're doing developmental screenings? So let's use those, let's look at that data, let's make sure those quality metrics are right, and let's think about tying some money to them instead of just nice job, bad job. And that is something you can do in the Medicaid statute, and that we want to look at and explore. I think I'm going to hold on a couple of these because we're going to come back with some specific state examples. But Donna, do you want to hit?
Sure. I want to talk about 2 additional tools that I think are being used. As Jocelyn said, the kind of the leading edge states, those that are kind of first into the fray, are few and far between. As I said to someone last night, state Medicaid agencies don't like to be first, but they really like to be second. Right? They like to see somebody else give it a try, learn about how to do things right, the pitfalls and all of that, and then you see an uptake of a new policy or practice. And so I want to give you some examples of where we have some opportunity there. So we can go to the next one. So one of the tools is about Medicaid payment policies and leveraging that EPSDT package, those components, to address the health of caregivers. Maternal depression screening and treatment is the example that I would use. I think most of you know about the importance of identifying and addressing maternal depression, not just for that caregiver, but also because of the effect on the child's development, on brain development. We could talk a lot about that. But when I was at CMS, I would get calls all the time, what are you doing about maternal depression? I don't know, what was I doing about it? What I didn't understand was that it had already been identified as a best practice as part of the pediatric well child exam. AAP had endorsed this, but the mom was not the patient. The child was the patient. The pediatrician didn't have the tools to address some of the issues for the adult, and also how do we get paid. We were able to use the statute, the EPSDT law, which looked at that risk assessment for the child and legally make the case that maternal depression was a risk to the child. And once we were able to do that, we were able to do everything that follows on. With EPSDT, if a screening indicates a problem, you then have to do further diagnosis. If the problem is surfaces from that, you then have an obligation to address the problem in whatever way medically necessary issues have to be addressed. And so we were able to put out guidance that allowed states to pay pediatricians not only to screen for maternal depression, but to bill the child's Medicaid, and also to conduct dyadic treatment that includes the caregiver and child together. We can talk more about that. Some of your speakers later, I think, have some direct experience with that. But this is an example of using the levers that are available to get the practices to line up with what we're looking for. I want to talk about an overlooked opportunity. It's an opportunity that's been there since the beginning of the Children's Health Insurance Program, but hasn't been used to a very large extent, and we would like to shine the light on this opportunity. For those of you who know about the CHIP program, you may know that built into the CHIP program is a rule that a state can use up to 10% of the cost of coverage for administration of the program. And the administration of the program are the things that you would think about as administrative costs, executing contracts, those kinds of things. But it's also outreach and enrollment. And it's also what are called health services initiatives. If there is room under that 10% cap, in other words, unexpended administrative costs, states can design activities and projects that help advance health care for children eligible for Medicaid and CHIP, and actually the whole population of children. And mostly in the beginning, states would do things like use it for their poison control centers, things like that. But they also have used those opportunities for things like home visits to teen parents, to help improve developmental screening. Most recently, when the crisis in Flint, Michigan became apparent, health services initiatives went to more information to the community about lead screening, but also lead abatement. Well, very recently, about a month, actually exactly a month ago, beginning November 1st, the state of Oklahoma, not known for diving into the fray all the time as a first, but implemented the first ever HSI to promote early literacy through well child care, through an HSI to Reach Out and Read in Oklahoma. First ever. The two things I want to mention here before we wrap up is that one of the reasons this is such a potent tool is because the federal share of costs in CHIP is greatly enhanced. The program was designed that way, and when I say greatly enhanced, I mean more advantageous than the Medicaid federal state share, but also with the Affordable Care Act, there was a very large bump to the CHIP federal share. So what do I mean by that? This activity cost the state of Oklahoma about $100,000. The federal share of this was over 95%. You have it, right? And so the federal share was over 95%. It means that the state of Oklahoma is paying about $3,700 for this activity. I talk about this because most states, not all of them, but most states have room under their administrative caps, and we should be thinking creatively with our state Medicaid and CHIP programs on how we can use those resources.
Absolutely.
Sorry, go ahead.
Okay, we're going to end with a few final slides.
Yes.
So we're going to move into the upbeat area. So we've kind of given you a little bit of cats and dogs on these are lots of things you could do. It takes a coming together, a whole community approach to really move Medicaid to become that tool we want it to. And we do have some kind of bright, shining star states that we want to lift up. So one is New York, which launched a First 1,000 Days initiative in Medicaid that is very focused on what Medicaid can do to support early childhood learning, early childhood health. And as part of that, they've picked a number of initiatives to focus on, including looking at supporting healthy steps, supporting reach out and read, centering pregnancy, the dyadic treatment that Donna's been talking about in home visiting. So this is the kind of activity that we want to lift up and create that crowd mentality around. The other one I want to flag for you is Oregon, which has very systematically gone about building relationships between its early childhood community and its Medicaid providers. Their Medicaid managed care companies are called CCOs. They are obligated to work, and they happily, I don't think it's a mandate kind of thing, they work with regional early learning councils to figure out how together they can promote kindergarten readiness through a variety of means. And I will say that's a state that very carefully looks at its quality strategy and puts some money behind its coordinated care organizations, seeing the kinds of outcomes that I think we want to see from an early childhood perspective. And then the last one I want to flag for you is North Carolina, which is just on the brink. It's historically been very strong on developmental assessments for kids, but it's about to undergo a major delivery system transformation under the leadership of a Secretary, Mandy Cohen, who's deeply interested in kids, including all of the social emotional factors that drive their health. She actually managed to eke out of the Trump administration $650 million to do an innovative pilot looking at social determinants of health and integrating that into the Medicaid delivery system. And managed care plans in North Carolina will be required, if they're part of these pilots, to look at stability of housing, to look at food security, transportation, and interpersonal violence and toxic stress. So some great states that we're going to keep lifting up so that we really make sure these Medicaid tools translate into supporting and scaling the work that you all are doing.
So in a number of states, I think we're sitting in one of them, there are some opportunities going forward in terms of new governors who have already laid claim to their interests in advancing health care for young children and their families. And we give you a couple of examples here. California, Governor-elect Gavin Newsom has talked about the Cradle to Career platform that he's going to be advancing. In Michigan, new governor talking about a child's first 1,000 days and how important it is. Here in Illinois, Governor-elect Pritzker, with I think a long history of being focused on the population that we're talking about, Maine as well, there are others. I think the thing to think about here is that there are new opportunities to bring these very concrete ideas and strategies to new governors and new Medicaid directors that may in fact follow, and to also remember that, well, at least in my experience, when we move forward on federal policy, very often it's because the states really have acted as laboratories, and we can learn a lot from what states do with the options and opportunities they have to then look at how to make things better more systemically. We saw that with the Affordable Care Act and outreach and enrollment and eligibility policy, and I think our time will come again. So we need to be looking at states with new opportunities available.
And I 100% agree with Donna, but don't want to leave out the feds. We, just so that you all know, there are some interesting opportunities coming out of the federal government, including a new request for states to step forward and get some money to do some planning around integrating care for kids across physical and behavioral health and social issues. And so this is like, we want to jump on that. We want to make sure that the states coming forward are integrating the kind of initiatives that you all work on. And then there's another one that is particularly focused on the opioid epidemic. So we're happy to chat about those, but some opportunities there as well.
Great. Thank you for your time.
Thank you.
That was fantastic. It exceeded expectation. Thank you all. I am going to start off with asking our panelists a few questions and then opening it up to the audience. I'll ask 3 questions. Of course, Jocelyn and Donna can decide which ones you want. But for Diane, I'll ask the questions and then you can each answer sequentially. For Diane, as the practitioners in the room are really trying to make a push to leveraging the healthcare system, what lessons or sort of set of lessons from economics should we keep in mind? Yes, please.
Again, I get asked these very broad sweeping questions. Am I on? Yeah. Okay. I think, so I showed the results of one project that looked at what happened when we pay doctors more to treat Medicaid patients. We see that they treat Medicaid patients. So I think one lesson that always comes out of economics is people respond to how much they're being paid. But that being said, I think the details are really important. And there are a lot of cases where people have come up with types of bonuses and things that they have found not to work very well. And I think in a lot of those cases, there have been cases where if you kind of, as an economist, look at the way that the incentive structure is designed, that you kind of see that there's lots of opportunities for people to respond in maybe unexpected ways. You see some of these programs being evaluated kind of sloppily and then expanded without doing kind of a careful evaluation to make sure it actually really works first. And so something that I would like to see is a lot of emphasis on kind of going into designing the incentive systems with an eye to evaluating them carefully first, having that being built into the design, and then making sure it's actually evaluated carefully before rolling it up.
Yeah. Very good, thank you. Jocelyn and Donna, 2 questions. One, I was really intrigued by sort of the semi-dual generation approach when we talked about maternal depression and leveraging Medicaid in that way. Are there other, there's a lot of discussion in early childhood about the importance of dual generation. You can't just treat one, it's really the total. Are there sort of innovative other ways that we can be thinking about leveraging insurances in this sort of dual generation approach, either from either end of the spectrum? So,
Want me to jump in? So, yes, there are. And it's actually very exciting. I was just at the National Association of Medicaid Directors Conference, and one of the groups of kids they are very focused on are the kids going in and out of child welfare. So that's sort of the easiest place to pull examples. But one of the things we're seeing states do is tell their managed care plans, you are not just treating this kid. You need to be doing support groups for the parents. You need to be doing training for the parents, both the foster care parents, but also the parents to whom the kids could return. And so as a Medicaid person, my antenna went up and I said, that means even for a less severe need population, part of what we can do is say we want to be providing training to parents in terms of speaking to their kids, interacting with their kids, and I think we should go for it.
very good.
I would just say, to add to that, I guess a couple of points on the child welfare example that Jocelyn gave. There are some new federal resources available through a new program called Family First, which is focused on identifying children at the greatest risk of entering foster care and making sure that doesn't happen. And it's a family approach. And so there's that opportunity, and there's obviously a healthcare piece too. But just to emphasize, I think the opportunity and the power of working with managed care plans and other players in the healthcare system is to talk about how to experiment with some of these ideas of looking at and treating a whole family, looking at what kind of flexible dollars they have so that they don't have to think about, this child is covered, but the parent isn't. How am I going to manage this? Thinking about how to use those flexible sources of funding to be able to achieve outcomes that are better for a child, better for family, and also have some cost effectiveness. And I think the evaluation piece of this is really important as well. And we're seeing that happen. I think that's happening to some extent with the Medicaid First 1,000 Days activities in New York and elsewhere.
Very good. And actually, the next question really pivots off what you said, experimentation. If you could direct a group of scientists, some of them in the room, what would you have them work on in terms of Medicaid and CHIP, or in any other areas? What questions do you need answered?
How long is the list?
So to me, the challenge is Medicaid is a pretty blunt tool, right? Like it can pay for things, it can set up. To me, the heart of what you do is to think about how to change pediatric practice, how to change interactions between parents and kids, and that's a fairly nuanced thing. And I know you're using the videos, so to me, that's the piece where we need more help. And once you've really identified it, then how do we turn that into something that Donna and I can write into a Medicaid managed care contract? Like,
right.
We want to see this training module, so we have to translate this very nuanced, rich work that you're doing into concrete requirements, incentives for plans. So,
and having that evidence base is very, very important. It's critical in convincing a Medicaid agency to change its contract language and its procurement practices. When they're looking at new ways of doing things, that is really important. And I like to think too, what we're all doing here by having our, our projects and our evaluations. To what extent are we changing the expectations of what happens when a family takes a child into a pediatrician's office? To the extent that we have enough of the spread and scale so that it becomes what pediatric practice is about, not just, my doctor does this cool thing, my doctor doesn't. When we change expectations, that's going to drive the way those contracts are written.
Very good. Well, wonderful. I'd like to now open up the floor for questions. Oh, and we have a hand in the air.
And Michael Saul, I'm from Developmental Pediatrics here. I want to emphasize excellent presentation, but there's a thing that worries me in your presentation about health insurance. And my mentor was the advisor to the Kennedy administration. And the original purpose of Medicaid was so that children would access community-based quality services, that you would get a Medicaid voucher and you could go anywhere. And one of the major problems with Medicaid is you can't access behavioral health services. You can't access parents who have depression, family support services. The list goes on, because traditional insurance never covered behavior health, never covered women's health, never covered the elderly, never covered disability. And much of the stuff you're talking about is hospital-based services. And hospital-based services are only a very small portion, an important portion, but a small portion of children's lives. And so if we're going to construct a system, how do we really do three things? Have continuity of the population. I take care of preemies, and they change Medicaid managed care numerous times with inadequate attention to EPSDT and continuity. I would just challenge you on the theme you mentioned, opiates. I've never seen an opiate kid get continuous Medicaid coverage and continuous early Head Start and preschool for all in North Carolina. I'll let the governors handle that there. The audits are lacking for the data we aspire to on a population basis. My intensity is how do we get that data and enforce what we know needs to be done?
Not all of it, but I'll take some of it.
Diane, we give you the hard ones. You want them?
Right. Well, I mean, first of all, thank you for your question and for your challenge, because I do think it is a real challenge. Maybe I can take a few pieces of it. You know, continuity of care is a really important piece. And when I talked earlier about states trying out and making progress on policies and practices that have been optional, one of the things I think about is the option in Medicaid and CHIP to offer children 12 months of continuous eligibility. In other words, once a child is eligible for the program, they keep their eligibility for a full year, regardless of any changes in the family income or circumstances. And the reason for that is to address some of the issues that that are embedded in your question. How do we treat a child who has, serious or not serious issue, but how do we treat them if they're in and out of coverage and therefore I see them, I don't see them? The 12-month continuous eligibility provision made that possible. And now we have more than half the states, I think probably 2/3 of the states that have picked that up. But that's one opportunity is to, again, I would just go back to it, make that the expectation, not, kind of the random chance that if you live in one place, you might have continuous coverage. If you live in, the state across the border, you don't. So I think designing policies and practices to address the specific issues that you're raising in your very specific but also broad question is, the way we can move forward.
Your answer is good on the coverage, but this is what I don't know. Why wouldn't a child born in Ohio or North Carolina with opiate coverage get a equivalent of a credit card that's good for 5 years? We know that they're not going to win the lottery. Right. We know that the family isn't going to have the miracle Hail Mary and the mom's going to start a .com and be a billionaire. We know all that stuff. But then you could show what the cost of missed prevention opportunities were, and you would find this simple device. My credit card works at the grocery store, the gas station, whatever would work for the kid. What is so hard about that as we have the technology to do it?
So I'm going to go with an amen with you. So I don't think Donna and I want to defend not taking that kind of long-term, let's just deal with the reality, and part of what that family needs is financial resources as well as health care. I personally am fixated on, we also got to help that mom, right? Like, it's really not that helpful, even if the kid gets the best care in the universe and has enough food, if the mom is still struggling, like, we got to help the whole family. I feel like Donna and I can't solve that with our existing Medicaid tools. But what we can tell you is we have advocated in the past for things like 5 years of continuous eligibility and enrollment, and that's the coverage piece, and I hear you, you also have a financial. So I would view that as kind of a challenge for all of us. We don't have answers in the existing statute, existing options. It totally makes sense to me. It is one of the few areas where there actually is some bipartisan interest because this epidemic hits everybody and because substance use hits everybody. So I think it needs to be part of do you do advocacy? An advocacy agenda, an educational,
we do science,
research, scientific-driven agenda, because we need something like that.
Right. And we have an opportunity through the new the new federal RFP that's about to come out to look at some ideas like this. And we don't have answers, but we have tools, and we could try some things.
Wonderful.
A quick note for questions to make sure that everyone joining via live stream can hear us. We'll be using the microphones for them. So my colleague Christy and I will be coming around with the mic to assist you.
Hi, Tom DeWitt from Cincinnati Children's. One of the big challenges that we have faced is the handcuffs that fee-for-service puts on us in Medicaid reimbursement. So I have a crystal ball question for all of you. To what degree do you think in the future that we'll move towards more of a capitated or value-based system that then allows us to do more creative ways of providing these services and making judgments of which ones are really critical to provide for which patients, and not being so tied to the requirements of a fee-for-service system that Medicaid currently has? And so my crystal ball question to you is, where do you see in the future, particularly Medicaid, moving more into that area, which actually then gives us the freedom and the ability to be very creative in terms of how we provide these kinds of services to our patients and families?
Crystal ball?
Sorry, I don't have a crystal ball, but I do think. So looking backwards instead of forwards, there has been for a long time all of the kind of waves of different types of experimentation with provider payment. But then when I saw the results from that AMA survey that still so much of revenue is coming from fee-for-service, it made me a little bit skeptical that kind of all of this talk of switching the paradigm is actually kind of happening on the ground.
And I was going to give you what I would like to see and then what I do see. So what I would like to see is a movement to true value-based payment where you get the resources, you figure out the smartest, most efficient way to help a family, whether it's medical care or whether it's support for the mom or whether it's some help with housing. I am, and just one caveat to that sort of vision, I do think all of the research that you all are doing and the quality metrics have to be central to that, right? Because there is still kind of a feeling of having been burned by managed care originally, that MCOs, isn't that what MCOs are supposed to do? And then a lot of times what they did is not provide as much care. Now we know you wouldn't do that at Cincinnati Children's, but if we don't have the quality metrics to go with the freedom to use the money in the smartest, most efficient way possible. Even the vision is problematic, but I do have that vision. I have to say, I share that deep concern. There's been so much chatter about it, and I'm a healthcare consultant, so like we've been chattering about it for years, value-based payment, alternate payment models, land, and it just hasn't moved that much. So I think we're at a critical point. I mean, we're kind of pushing that direction. We think it makes more sense. But it's interesting how much staying power it does have for fee-for-service.
Also, just with the quality measures, I think a kind of general insight from economics about these types of very difficult to measure type things is you really have to be sure that you're getting the measure really right, because then you can get all sorts of kind of teaching to the test type things. Everyone gets to 100% on the quality metric, but then you've kind of left behind what you were actually trying to measure in the first place.
Hi, I'm Julie Holland. I'm the head of general pediatrics in a North Shore University Health System, which is a local healthcare system. And I wanted to talk a little bit about an idea, which I'm sure we've all talked a little bit about, this idea of universal healthcare. So, I will tell you that as a general pediatrician for several years, regardless if patients have private or Medicaid or government insurance, there's still an incredible fragmentation of their care, a lack of ability to access records. And a lot of times it doesn't really matter if you're privately insured or governmental insured. I think there's been some improvement lately in certain states when they've been working on immunization registries and other things. But if you have a kid that's born in Ohio who's a preemie with multiple issues, and they show up in Illinois 3 years later or 7 years later, having a 1-year eligibility or 5-year eligibility doesn't do very much for that kid when they're in first grade. And so I think this incredible fragmentation we have with 50 different systems of Medicaid really doesn't ultimately help children that much. And looking at how Medicare works, I mean, my understanding is that it's a much more federally based program. There's national standards. You can compare the hospitals and outcomes in Ohio to Illinois. And seems that really, in my mind, is the system we should be working towards, so we can really stop fragmenting the care based on whether you're privately or publicly insured. And again, I don't think that matters a lot. I think care is incredibly fragmented, and it's really hard to deliver care for these kids. And certainly the kids that are the poorest are the most vulnerable. If you were living in North Carolina and you were poor there and you moved to California and you re-enter the state foster care system there, these kids have terrible outcomes. And I think part of the reason as a pediatrician I can't do more for them is I have no idea what happened in state X or Y and no ability to move forward based on that information. So it's a long-winded way of saying, is there any ability to really think about trying to make these programs more national, with more national standards and more national access to these kids' records?
So I think there's, I don't know if anyone else?
Yeah.
Medicare for All 2020.
Right. Right. People have been talking about this.
It would have made my presentation a lot easier.
Right. You could have had one slide and said, here it is. It's true.
But I do want to take the comment seriously, because in the sense that you are raising critical issues around this disjointed care that we offer kids who just need a little bit of continuity, and it makes absolutely no sense. So there have been bills in the past, Democratic senators who have looked for essentially Medicare for all, and I know AAP has sponsored that, not sponsored it, heavily endorsed it. It's something that, to be frank, in the current political environment does not have a lot of legs, so do not want to sugarcoat that. So I think there's a strategic choice for folks, like how much do we keep pushing on that idea if that's what you see as the solution, and versus, or maybe do we also push on some interim, more kind of IT-based sharing of information across states? I do know we finally just got, it was actually in the opioid bill of all things, a provision, you know how Medicaid needs to cover foster care kids up to age 26. It used to be that if you moved from a different state, that didn't count. And so they cleaned that up and said, if you're in foster care in any state, we're going to cover you up to 26. I think they are actually now trying to figure out exactly how they're going to share the data to make sure that happens. So to me, it's a strategic choice for folks, is how much do we push on a single unified program, a la what AAP has asked for over the years, and how much do we work on kind of interim, not that satisfying, but somewhat helpful solutions to help on the continuity.
But I just think, there are examples of sort of that two-track approach. Don't let your vision fade, right? Keep that, strong if that's what you believe, but there are ways to to kind of drive the train there. And, again, the example that Jocelyn used about, the foster youth who moved from one state to another and now they have no health coverage. It took about 2 years, but it got changed. So again, that's incremental, that's small, but pushing all those pieces together and keeping that vision very strong, we can get there.
All right, we've got one more question over here.
My name's Isabel Geffner, and I'm with a CBO in North Carolina that looks at literacy. So I appreciate your indulgence of our presence here.
All the kudos to her.
And, I also appreciate really what you were saying, that sort of macro view and macro vision is essential to keep in mind in order to really, dare I say, revolutionize the way things are proceeding. And currently at this moment, just having an understanding, certainly for us and perhaps for the physicians and other practitioners who are here, knowing where there are opportunities currently. We are so faced day to day with what's right in front of us that we often don't have the opportunity to see or understand where there are, in this moment, opportunities for both funding and policy serpentine pathways to make things happen. So, having that information, just little notes that I've taken here, or other ways that this conversation can continue, can help move us to ultimately, hopefully, what would be universal.
We'd like to help you push the buttons.
Right. Thank you.
Sure.
Thanks, Dana. Frank Belmonte, advocate of Aurora Health. One of the questions that you kind of alluded to early in the talk was the siloing of the funding. And I wonder if we could talk a little bit about, I think what's really holding us back in this country as opposed to many countries around the world is that we silo the funding into the healthcare bucket, into the education bucket, into the welfare bucket. How do we start to move short of single payer to start tracking that dollar between the different buckets? Because I think that's also what's holding us back. I may do something in a healthcare system that impacts the education system. How do I give credit for that? I think this is really holding us back right now.
Yeah.
I totally agree, and I was trying not to be greedy when you asked the research question, because that was my second research ask for you all, that our researchers is help us figure out how the investments in healthcare play out and have a concrete financial impact on criminal justice, education, and those kinds of things. So I think we need a stronger research base. I sound like an economist. Like, we need more research.
What do you think, John?
Research before we need a stronger research base. I also think, though, we need some policy options, because I think we're going to find what we want to find, that it makes a difference. And so I think we need some policy options. There has been a fairly angst-filled conversation about should we be braiding together healthcare funding with, for example, child welfare, criminal justice. There
Food
is,
assistance.
frankly, sort of a deep residual concern that if all the funding is lumped together, which is sometimes where you head, that will end up with a block grant that's both pretty easy to cut at the federal level, and also from a kid's perspective, a block grant can risk that some of the really high cost folks end up consuming more of the spending. So I totally agree we should do it. Again, I don't feel like we have answers yet, and so it may be one of the creative ideas, both the research base for the impact on cross-sector implications of some of these early intervention investments, and then also some kind of policy research on ideas about how to weave the funding together, without risking
With guardrails.
one big block grant.
With guardrails.
So just really quickly, I kind of have a question for you guys you women along this line. And so to your point, even without kind of combining the funding, the state is kind of funding all of these things through different buckets, but it's still the state at the end of the day that is doing a lot of the funding. And so I've done some work in New Jersey, working at the Department of Health, and then you try to ask about, but what about the foster care system? And they're like, well, we don't know any of the people there. That's a totally different building. It's and you would think that those types of systems should kind of talk to each other.
Mm-hmm.
And so I was wondering if you have any experience in kind of how you can make that happen.
Well, in New Jersey, they could cross the street. So,
But they don't.
But
They don't
right,
go outside.
having worked there for many
Put
years,
a
I know.
Starbucks in the middle.
Right. but to treat it seriously, I mean, I do think there are, some states and communities that are looking at, cross-sector approaches and figuring out kind of, to the previous question, if I'm going to come out better on the other end, is there some investment that I should make at the front end to see that it happens, right? So I know that there's some, discussion of that and some very concrete examples of where those things are happening. But to the point of, state agencies where, people aren't talking to each other, I really do think there's an advocacy role and a leadership role to bring people together with common goals and objectives. And I know that sounds like just like words, but we were recently talking with the folks in Oregon and talking about the school readiness goals that they have, and the pediatricians saying, we really care about school readiness, but you can't hold us solely responsible for school readiness. And it was that financial incentives that they had around that quality measure that forced a community-wide coming together of the different players, and now they have what Jocelyn was describing earlier, the healthcare component and the early childhood hubs working together. So, you know, we're seeing these, you know, marriages being made. So, I'm hopeful.
Am I on? Thank you all for a truly stimulating panel and discussion.